So welcome everybody, and welcome to Partners in Pain. My name is Susan Tupper, and I'm going to be your facilitator for this evening's session. I'm really looking forward to the information. I always learn so much when I hear these speakers share their information, so I'm looking forward to that, and thanks everybody for joining us. So before we begin, I just wanted to offer a land acknowledgement and just make note that where we are in Saskatoon, I'm in Saskatoon, that's considered Treaty 6 territory and homeland of Métis. And I know that there's people calling in from all over. Regina and Yorkton area are both Treaty 4 territories, so just wanted to pay our respects to First Nations and Métis ancestors of this land and reaffirm our relationships with one another. So just a little bit of a background on Partners in Pain. So this initiative grew out of the Improving Pain in Saskatchewan Collaborative Research Project and a collaboration with the Saskatchewan Pain Society, or SaskPain. And we received a Community Initiatives Fund grant last year and are very grateful for the funding from that. And we have another sponsor for today's session as well. So the Saskatchewan Workers' Compensation Board also provided some funding. And we're very grateful to their support as well. Just a little bit of webinar etiquette that I'm sure many of you are aware of after the last couple of years of being mostly online. Just a few reminders to mute yourself, keep yourself muted while the speakers are presenting, and that will just reduce some of the background noise. And we're very happy to see people's faces. So if you can turn your camera on, give us a wave, we are happy to see you. But if you are having some problems with streaming, and need the bandwidth, then turning your video off usually helps with that. There's going to be an opportunity to ask questions throughout the sessions. So at that time, you can either put your questions into the chat box. That's an easy way to do it. But if there's opportunity, I'll invite people to unmute themselves and ask their questions as well. So, and if you put your question into the chat, myself or one of the other people that's monitoring this will be able to ask your question to the presenter. So our first speaker for today is Kelly Kizlyk, and Kelly is one of our SaskPain board members. She's a pharmacist with iOPS Chronic Pain Clinic in Saskatoon at the University of Saskatchewan, and she also works for MedSask, a drug information service. These are two very important services for people living with pain in our province. Kelly has been a pharmacist since 2002 and worked in community and hospital settings. And she is passionate about hearing patient stories and building relationships, and looks forward to the opportunity to help patients live well. Kelly is originally from Yorkton and now lives in Saskatoon with her husband and 2 young children. And she enjoys playing Barbies and Uno and sleeping in whenever opportunity presents itself, which I'm sure is not very often for you. But thank you very much, Kelly, and we will turn it over to you to share your slides and give your presentation. Thank you.
Sounds good. Thank you, Susan. And thanks to everyone at Partners in Pain for having me. My 6-year-old actually came home and announced that we have to set leprechaun traps. So I don't know what that means, but that's what I'm going to be doing over the next 2 days is figuring out how to set leprechaun traps. So anyways, it never ends. If anyone has any tips on that, I'm happy to hear about it. All right, I'm going to get started with sharing my screen. I did bring some slides, mostly to keep me on task because I have a tendency to go over time. So let's get all this technology loaded up. Okay, Celine, if you want to give me the thumbs up to let me know, perfect. All right, so like Susan said, my name is Kelly, and I'm here to chat with you folks today about medications for chronic pain. Oh, and I can't out and bounce. There we go. So I always think laughter is the best medicine. So I like to throw in a quick joke every now and again, just to lighten things up a little bit. And I thought this was a little bit of a funny joke. We've combined all your medications into one convenient dose. So good luck swallowing that one. Anyways, one of the first things that I do when I start to talk with folks about using medications for managing chronic pain is basically to talk myself out of a job. And essentially where I start is to remind people that although medications are one of the helpful tools in our toolbox, it certainly shouldn't be the only thing in our toolbox, right? And the only thing that we rely on to help manage pain. So in my work as a pharmacist, I often use the 3 M's. So medication, movement, and mind strategies. So as a pharmacist, I work with the medication strategies, and our team also includes a physiotherapist to work on the movement strategies and a social worker to work on mind strategies. Another thing that I've come across is the 4 P's of managing pain. So you can see that image on your screen as well. And that's also another helpful way of looking at the strategies that we should be using to help manage pain. And where those 4 P's might come in handy is when you think of chronic pain as a car with 4 flat tires. So if you only look at a single treatment like medications, for example, it would be like putting air in only one of those 4 tires. And you really need to fill the other 3 tires if you're going to get anywhere with that chronic pain car. So having said that, my task today is to talk specifically about medications for pain, and that's where we're going to spend the next couple of minutes chatting. So, oh, my screen is frozen here. There we go. So the first place I thought we'd start is to start looking at actually how medications work and where they work. And I like to compare this with my experience with cooking, because yep, I can follow a recipe. I can end up with a decent meal for my family, but I feel like it's when I know what each of those ingredients are and what they do that I can really do a much better job with my cooking. So same thing with medications. It's important to me that you know where they work and how they work, right? And because I know, for example, how baking powder works, I only use it in baking and not barbecuing. Although having said that, it's excellent with chicken wings. But that's part of my philosophy as a pharmacist. I want you to know how these medications work and where they work. So we're going to start with a really basic overview of how pain works and how you actually feel pain. So I'm going to start at the bottom of that picture. Now you have to forgive me. I'm not a graphic designer by any means. And so this is kind of a quick graphic I pulled together to describe the pain process. But basically, if we start at the bottom of that picture, all over your body are millions of nociceptors. And these are kind of like danger sensors, right? They're constantly monitoring what's happening, and they're responsible for picking up on signals that come in from our environment. So those nociceptors, they pick up on these signals, and those signals travel up along peripheral nerve fibers. So peripheral nerves are the next step. And those nerve fibers take that pain signal to your spinal cord, which ultimately takes it to the brain, okay? Now, those peripheral nerves, they release chemical messengers like neurotransmitters. That's what tells those spinal cord nerves what to do. Once again, there's chemicals and neurotransmitters that are in your spinal cord and impulses that are sent up your spinal cord to your brain. When that message eventually reaches your brain, it's sent to all different areas actually of your brain. And it's all of these areas of your brain that work together to process the message. If your brain thinks that there's a warning and that it's justified, that's when you experience pain, okay? Now, and then the brain responds, right? It sends a response back down so that let's say, for example, you did step on a pin, it tells you, ooh, pull your foot away, right? That's your response to pain. So this process kind of describes nociceptive pain, or probably one of the more common types of pain, which basically there's some sort of harm, or the body has picked up on something that's potentially dangerous to body tissues. Now, this process also describes neuropathic pain, but the origin of that pain is a little bit different. And so that pain comes from some nervous system damage, right? So it might be an injury to one of those nerves caused by, like I said, nerve damage. It might be an infection. It might be an injury, some sort of illness. And so that's where neuropathic pain comes from. So nociceptive pain is those nociceptors responding to signals from, outside or danger signals. Neuropathic pain is when there's damage to our nervous system. And then there's another type of pain called nociplastic pain. And that is where there isn't necessarily damage that's been caused, but somehow our brain and our body is still sensing pain, right? There's some sort of pain signal that's still being produced. Now that I've got you all maybe a little bit closer to a degree in anatomy, I want to kind of tell you why this is really important. And first of all, it's complex. And I gave a really big high level overview. This is actually a really, really complex process. And pain doesn't just come from your foot, right? It doesn't just come from your back. It doesn't just come from your shoulder. It's part of why you might have heard before that pain comes from your brain. And it's not that pain is in your brain or in your head, right? It's just that your brain and your central nervous system are ultimately really responsible for what you're feeling. The other thing that we've come to learn is that there's changes to this process, right? That happen with chronic pain. And there's actually changes in how you respond to pain. So with chronic pain, your central nervous system is actually much more sensitive to stimulation. So you might feel pain when you actually, when there isn't really a danger stimulus around. You're more sensitive to it. Things that didn't hurt before are now hurting. And this is why sometimes taking more ibuprofen just doesn't cut it, right? It's why you might feel like you're taking way more medications. And as you see in the next couple of slides, we can use medications to tweak some of these things that are happening in the pain process, but it does take several strategies, right? It might take more than one medication. It might take medications combined with our mind strategies and our movement strategies. And I often compare this pain process to the wiring in a house. It's an analogy I like to use in the conversations that I have with folks. And if you think about an electrician coming to your house with just a hammer, it might help you realize why we talk about having, lots of tools. So maybe more than one medication and more than one strategy in our chronic pain toolbox. Okay, here's my next slide, and how's this for a really, really busy slide? But essentially, this is another slide that has some big general information about the different types of medications that we use for pain at a bit of a high-level overview of where they work and how they work. So you can see at the bottom that some of them work maybe at the site of the injury, right? Others work on how our pain messages are sent along our spinal cord and up to our brain. Some of them work in our brain and how we perceive pain, and yet others work on how our brain responds to that pain and the signals that it then sends out for our bodies to respond to the pain. Once again, I don't want you to necessarily know all of this or commit this to your memory, but what I want you to take away from this slide is that medications can work all along that pain pathway. And once again, if you think about my analogy of comparing this wiring to the wiring of your house, you can appreciate that months and years maybe of a wiring issue isn't just fixed by changing one plug, right? It sometimes takes some tweaks and some changes and some alterations and thinking about all of the different places where there might be a problem or an issue and where we need to address those issues. And we have to target more than one place, right? And then, looking at this and where all of these medications work, you can realize that sometimes medications also cause some other effects, right? They might not just work on pain, they can cause other effects. They might also cause some side effects because of where they work and how they work. And so although we don't have a lot of time to really discuss specific medications in a lot of detail, I just wanted to highlight a few of the medications that we might use fairly regularly in managing chronic pain. So I thought I would kind of speak specifically to the SNRIs and the TCAs. So these are both antidepressant medications that we use to help manage chronic pain. And basically, I said the word antidepressant, but they work on the neurotransmitters that we target for depression are also neurotransmitters that are involved in how pain signals are sent in and around your body. And so two neurotransmitters specifically called serotonin and norepinephrine, that's where medications like SNRIs or TCAs, tricyclic antidepressants, work on modifying how your body responds to pain. Basically, what those neurotransmitters do is change, like I said, your body's response to pain. So taking these medications can basically help turn down what might be an amplified or exaggerated response to what your body is perceiving as painful. Anti-convulsant medications, so you might have heard names like pregabalin or gabapentin. Those medications work on how nerve impulses are sent, right? So the way that your nerves and your spinal cord send messages up to your brain, that's where pregabalin and gabapentin work. So if you're happening to experience neuropathic pain, those medications might help to relieve some of that pain. And then anti-inflammatories, so medications like ibuprofen and naproxen, those work at the site of injury or inflammation on something called prostaglandins. And prostaglandins are substances that are released when something is injured, and they typically lead to inflammation and pain. And so when we work on those substances with a medication like an anti-inflammatory, it can change that inflammatory response and that pain response. So obviously, I'm just keeping an eye on my time here. We don't have a lot of time to take a deep dive into all of these medications and how they work, but this is definitely something that your pharmacist can chat with you about. We can help you understand how and where your medications work so that you can take them more effectively and efficiently, and really be thoughtful about how you use medications to help manage your chronic pain. All right. Oh, my slide won't advance again here. There we go. And then I did mention before about how we have to use a variety of tools or tools in our toolkit when we're managing chronic pain. So in the way that I just showed you where some of the medications work, I just wanted to include this little slide about where some of the other interventions actually work, right? Because I know when we start to talk about mind strategies and movement strategies, there is actually like a physiological response that your body has to these other strategies. So for example, endorphins are a natural neurotransmitter that are in our body. They act at many levels of that central nervous system, including our spinal cord and our brain, and help to control our pain response. And endorphins are something that are released with exercise and activity, right? Relaxation techniques. So I included, even things like cognitive behavior therapy. Some of those techniques are actually shown to have a response on things like norepinephrine, those neurotransmitters that the drugs work on. So those other strategies are really, really important and have an absolute physiologic response in our bodies and on that pain process. So some of my colleagues as physiotherapists and social workers and psychologists can probably speak to some of that science a little better than I can. Now that we've kind of had a bit of an overview of medications and how they work, there's a few other things that I really wanted to highlight in talking to you folks today about using medications in managing your chronic pain. And these are things that are really important to me as a pharmacist, and I want them to also be important to folks that are using medication. So the first thing that I like to talk about when I'm chatting with folks about medications is dose and duration. And one of my philosophies as a pharmacist is to always use the lowest effective dose. And both of those are important, right? The lowest dose. There's no sense taking more of a medication than you need to, right? That can just lead to adverse effects. But effective, you also want to be making sure that the medication is effective for you. There's no sense taking something if it's not actually working. So lowest effective dose is important. And duration is another important consideration. Some of these medications work right away. You might notice a response within maybe an hour or two of taking them, right? Taking an anti-inflammatory or Tylenol for your pain might work quite quickly. Some of the medications that work on those pathways have a fairly rapid effect, something like pregabalin or gabapentin, but it might be when you take them more long-term that they really have a better bang for your buck. And other medications where they're working on those pathways and maybe something that, months and months of chronic pain have kind of led to, it can take weeks for them to really start being effective for your pain. So if you're looking at using something like a tricyclic antidepressant or an SNRI to manage your pain, we often need to look at a duration of weeks for them to start to be effective. So both of those are really important when you're thinking about medications. The second conversation I like to have with folks is around benefit versus harm. And it's a scale, right? It's a balancing act. So I want you to make sure when you're considering a medication that you're well aware of all of the potential benefits that medication might have for you. And then what harm? So what are some of the side effects? What are some of the risks of taking that medication? And you need to weigh that out, right? We need those benefits to be greater than the harms to know that that medication is something that's going to potentially be effective for you. And, when we talk about benefit, it's really important to me that folks know what to expect from their medications and that they have realistic expectations. And one of the things that I like to highlight when it comes to using medications for chronic pain is that most of these medications are not a silver bullet. I would say all of these medications, right? It's really tough for me to say that these are 100% effective. And when I talk to folks about what you can actually expect, many people don't necessarily realize that for pain medications to be labeled as effective for chronic pain, what they have to show is a 30 to 50% reduction in your pain. So if you're expecting 100% reduction, that's not going to happen. And the reality is that somewhere it's in that neighborhood of 30 to 50%. So if you're sitting at a 10 out of 10, I might be able to get you to a 7 out of 10, best case scenario, 5 out of 10. So you need to know that when you are taking a medication. The other thing that I like to talk about when it comes to benefit is really focusing on functional improvements, right? I just gave you the example of numbers and saying, oh, well, I got you a 5 out of 10 with this medication. I like to focus on functional improvements. You know, is taking this medication helping you to get up and moving more, right? If your goal is to be able to walk to your mailbox every day or every other day, is this medication actually helping you in being able to move to your mailbox every day? So those functional improvements are really, really important. And kind of my final statement on this slide is how important individualized therapy is. Everyone is completely different. These medications work differently for you. You know, the worst thing I can do as a pharmacist is to give you something without considering all of your individual, you know, preferences and values and what's important to you when you're taking a medication. Those risks and those benefits are also very individualized, right? When we think about something like drowsiness, for example, you know, for some folks, that's a really big risk. If you're driving, if you are responsible, if you're a caregiver to others, you know, that drowsiness could be really, really significant. Whereas, you know, if you can maybe tolerate some drowsiness and you're getting some benefit from a medication, you might be more willing to tolerate that risk. So individualized therapy is really, really important. So I want to make sure that that you folks also really consider that and are vocal about some of your individual preferences and what's working and what isn't. And finally, I thought that I would just take a quick stab at if you're looking for some more information and kind of wanting some additional information about medications. So certainly there is a lot of stuff online. And when I'm talking to folks about managing pain and using medications, a lot of them tell me about, oh, I read this on this website and I read this on this website. And so just a note of caution is to use reputable websites. And on this slide is pictured our MAC iOPS chronic pain toolkit. And this is a resource that we've pulled together. And there actually are some websites that are included in our toolkit, and you can access that maybe in the notes that we share to everyone participating in this session today. I can include a link to our chronic pain toolkit, but you know, just beware with some online resources to make sure that it's a reputable source and not just someone's opinion about using a medication. So a word of caution. Some of the places that I like to refer folks when you're looking for information are to healthcare professionals, right? And maybe I'm a little bit biased as a pharmacist, but certainly talk to your doctor, talk to your nurse practitioner, you know, whoever's prescribing these medications, ask them the questions, talk to them about it. Your community pharmacist is a really, really valuable resource when it comes to talking about medications. It's what we do. And so, you know, when you want to know, how does this work? What does this do? What are the benefits? What are the risks? Chat with your community pharmacist about that information. And then here's another shameless plug for the work that I do. So like Susan had mentioned, I work for MedSask, which is a drug information service. And you can certainly call us. I'll include that contact information in the information that Celine sends out to all of the participants after. So if you're interested in, or if you have a question about the medications you're using, you can call our team of pharmacists and we will answer some of those questions around your medications. And I believe that Taylor is going to speak a little bit more to what pharmacists do and, you know, how we can be involved in help managing your chronic pain. So I look forward to hearing that presentation a little bit later on. With that, I hope I didn't overwhelm any of you. I always feel like I speak very, very quickly and try to cover a lot, but I'm looking forward to if any of you have any other specific questions or any other comments about what I've shared with you today. And once again, thank you for listening.
Thanks so much, Kelly. As always, that was very informative and lots of great information and resources that people can follow up with afterwards. Does anybody have any questions? If so, please feel free to pop it into the chat. I can read it out to Kelly, or if you'd like to unmute yourself and ask live, that is also acceptable. Dana says, great presentation, Kelly. Excellent information. Well done.
Kelly, I have a question for you. You showed us a slide with lots of different examples of different medications and different classes. Do you commonly see that people are on multiple medications at a time, or what would be your preference if you were to think about, how the big picture looks for a lot of people on pain medications?
That's a great question, Taylor. Thank you. And I think it comes down to, once again, where these medications work, right? And I hope that from that slide, you can see that oftentimes we're kind of targeting different and maybe specific areas where these medications are working in that pain pathway. And so certainly there can be a role for using different types of medications when they are working, in different areas. Now, what we need to be cautious with is sometimes, when we use combinations of medications, it can lead to additive side effects. So we might want to prioritize certain medications over others. But certainly there could be a role for using medications from different classes. Sometimes they can work synergistically, right? And so the effects of one can kind of complement the effects of another. So I think that's a really important part to highlight when it comes to using combinations. And, I think that our work in chronic pain as chronic pain pharmacists, we see that pain is not just one of those things, right? Pain is often many of these things. So it's that nociceptive pain that I spoke to. It can be that neuropathic pain and that nociplastic pain. And so when you get pain that is complex, it sometimes takes several different strategies to really target all of those different areas. So definitely there can be a role for combinations of medications, with the caution that, sometimes with combinations we can get, more additive side effects, maybe some drug interactions that we need to be thoughtful of. And really what it comes down to, and I think one of the rules for your pharmacist, and you'll probably speak to this later, Taylor, is to really take a critical look at what you're taking, why you're taking it, right? How much you're taking, to make sure that we're optimizing these medications. There's no sense throwing a whole lot of stuff at you unless we're using them all optimally. So does that answer your question?
It does, Kelly, and I think that really reflects my experience too. So you're right, I do have a few pieces of information to share about this in my section as well.
Great. So I have a question. Is there a wait list to be seen by somebody at MAC, or like the MAC pharmacy, not MAC iOPS, but the MAC pharmacist, or a wait to talk to a pharmacist at MedSask?
Great question, Susan. So I might pass the MAC specific question to Taylor, because she specifically works with MAC, which is the General Medication Assessment Center that reviews, all therapy. So I work specifically in the MAC iOPS, which is more directed at chronic pain, and it is more than just a pharmacist, right? So there's the pharmacist, the physiotherapist, and the social worker. And we do have a wait list. We're actually just working out what the wait list looks like. I don't have a specific time frame for you right now. We've recently added some new staff, so we're working on our wait list as we speak, our processes. So there is a wait at this time. And then when it comes to MedSask and the work I do at MedSask, it is what I would maybe call an on-demand service. So you call us and you chat with the pharmacist right away. You might have to leave a voicemail, but I can tell you that we do usually get to our voicemails very quickly. So usually within the day, you can let us know the urgency of your question so that we can respond, as quickly as possible. So with that service, it is, you call us and we talk to you at the time. Now, an important maybe highlight between those different services is MedSask. So we're a team of pharmacists that are directed at answering questions about your medications, maybe your supplements, some natural health products. But what we don't have is kind of that full picture of your care. So I don't necessarily know all of your conditions. I don't know all of the causes of your pain. And so we're in a position where we can answer maybe some specific questions about a specific medication, but it's not always appropriate for us to make recommendations, say, about your pain medications, because I don't have all the information that I need. So MedSask is great for those, specific questions. What are my side effects? What side effects can I expect? Or, I just started amitriptyline. What drug interactions do I need to worry about with my other medications? But when it comes to individualized recommendations, I would refer you to either the Medication Assessment Center or the MAC iOPS, the Chronic Pain Clinic, or, one of your primary care providers, so someone like your physician or your nurse practitioner, to really look at making some of those general or broad specific recommendations, I guess.
Good.
I'll just quickly chime in, Susan, about the General Medication Assessment Center. So myself and my colleague Eric both work half-time there, and we generally can see folks within about 3 to 4 weeks from their referral. So we have a much shorter wait list than the chronic pain side of things. So if you want a comprehensive medication review to have a pharmacist go through your medications, and I'll tell you more about that in a few moments, you can refer to the Medication Assessment Center, and we can generally see you within the month.
That's great. So one other question, quite often people with chronic pain have multiple other health conditions, and so they may have received one prescription from one provider, another from another, or they might go to the emergency department or have a surgery, and they end up kind of with this bag of pills. How often should people be, I guess, either talk to their pharmacist or their physician to kind of get somebody to take a look at everything rather than having kind of all their health issues chopped up into little segments?
Oh, that's another great question. And maybe as a pharmacist, I would like to say well, all the time, Susan. But I think maybe if I have to give a more specific answer, anytime there's a change, right? Anytime anything changes. So whether that's a change to your drug therapy or maybe a change in how you're feeling or a change in a side effect, I think that's a really good opportunity for you to look at all of those medications and kind of taking a step back at all of them. So that would probably be one time. Anytime you're concerned about it, right? Maybe it's nothing has changed, but maybe you as a patient are a little bit concerned about your medications. That's another good reason to go and have a look at all your medications and sit down and have a conversation with someone. Maybe it's another caregiver or a loved one that has suggested to you, oh, I noticed that you're taking medications. That might be another reason to review your medications. Certainly sometimes pharmacists, we might suggest an annual check-in with your medications or every 6 months, but certainly there isn't necessarily a magic number. And I think that as a person taking medications, if you feel like you want to have those medications reviewed, that's the time to do it, right? That's the time to do it.
That's great. Thanks so much, Kelly. I appreciate that. All right, so seeing no other questions, it's time for us to move on to our next section, which is to hear a lived experience story from Giselle. So Gisele Cook is our next speaker who's going to be sharing her story. And actually we're going to do this in a bit of an interview style. So Taylor is going to actually ask the questions and Giselle will provide her answers to those. So just to give you a bit of a background on Giselle, she said she's pleased to share her experience of living with pain with us. And she is 58 years old and says that being a grandma is the greatest honor of her life, which I am excited for someday, hoping one of my children will end up giving me a grandchild. In the meantime, I will be happy with dogs. But all right, thank you so much, Giselle, for sharing your story. And over to you, Taylor, to ask the questions.
Excellent, Susan. You sound like my parents, just begging and wishing for grandchildren sometime soon. And it's not happening anytime soon. I always have to tell them. So don't get your hopes up as a mom too soon. Oh, Giselle, it's so nice to see you. We've talked before, but only ever on the phone. So now I get to see you in person, which is so lovely. Well, not in person, but the next best thing. So I'm so looking forward tonight, Giselle, to you sharing your story with the rest of the group here, because I know bits and pieces of it. And I know how far you've come and how hard you've worked. So I'm so looking forward to you sharing your story, because I know it's going to inspire at least one other person here tonight. And that's really what we're here for. So my first question for you, Giselle, is if maybe you could give us an overview about your pain journey, like going back to the start, what happened along the way. Give us an idea of what your story's been like.
Okay. Can you hear me?
We sure can, Giselle.
Okay.
We can hear you.
Hi, everyone. I'm totally out of my comfort zone here, but I couldn't not participate because of my experience with MAC iOPS that has changed my life, completely changed my life. So it was an honor to be asked, and I'm happy to share whatever I can. I I was talking earlier, I don't even really know where to start with it all. I started having an aching back when I was 12 and was taken to chiropractors. I was taken here. He'd crack me and put me, crack, whatever they called that, and put me in more pain every time. And I was pretty a husky girl, as they called it, growing up, and that was blamed on everything. You know, if I was more active, and that I was making up stuff, and I just didn't want to go to school, and just things like that. I had really bad teeth. I was my mom. I was born in 1963, and my dad was a public health officer. That just when thalidomide and everything was being handed out, and mom refused to take thalidomide, but she took a calcium enhancer or something that, but it removed all the enamel from my teeth. So I had rotten teeth and suffered abscesses, and it just stuff like that, on and on. And I just kind of learned to, I don't know, suck it up or whatever you want to say, because everybody kept, you know, just poo-pooing it. And if you lost some weight, maybe if you quit eating chips and all this. And then I don't know, it just kind of carried on from there. Like I say, I accepted. I was very active. I worked really hard on the farm with my dad. So that was not an issue at all. I was a kind of a tomboy and always was steady, very, very busy. When I graduated, after I graduated grade 12 and moved away, all my jobs were quite physical jobs for quite a long time. I got married quite young also, and had 3 C-sections, 2 of which were emergencies. So that started a big pile of ouch for me there. I had serious infections in 2 of them and had to go back to the doctor, and back to the hospital, sorry. And that started a bunch of stuff with home care coming every day for 3-4 weeks. And when I was in 1992, I used to weigh 400 pounds. And in 1992, I had my stomach stapled and I lost a whole self. I lost 200 pounds basically. But that was, it was very bad, because you're starving yourself to death is what you're doing basically. And that created, I think that just added on to my whole big issue. Then I had skin removed, and I had bad infections with surgeries, on and on, stuff like that. It just delved into a whole bunch of other areas, but then in 2012, we were in a really bad motorcycle accident, and I had a head injury. I had no broken bones, just road rash and some really serious trauma, but I worked through the trauma of that. My head injury caused me a serious aversion to anything medical, to physio. The first time SGI, we had to take physio and all that for insurance purposes. And the first time I walked into Barassa's gym, I had one of the most serious meltdowns I've ever had in my life. It was everything. It was horrible. It was my head. They were addressing my body, and it was my head that needed fixing, not my body. Physio was included in that. I convinced myself that it was a scam, that it didn't work, and all this and that. Where do I go from here now? Like I always, had really bad earaches. I've been dizzy since I was a child due to that. And that was always, again, I was faking. It gave me sore stomachs. I'd lose my balance. That was just pushed down to, oh, you're just so clumsy. And, it was just a whole big pile of pain stuff that I just learned to push way down far and carry on. And I think the trauma of the motorcycle accident maybe kind of brought everything to the top. It wasn't just that the accident itself, it was a bunch of other stuff that came to the top. And so I went through to a really good, he was an actual psychiatrist, Jim Arnold. He really helped me very, very, very much, and taught me all kinds of stuff about trauma that I used a lot of that to put into my pain, and realized like how much of all that is connected. I don't think I ever really got over the motorcycle accident. I lost lots of my cognitive ability. I used to be a reader, a bookworm, where I'd have 3 novels going at the same time, and I could write very eloquently, and I lost all that. I lost my ability to sew and to read and to, so I had to get used to all that stuff. That's never changed, but I've accepted it and can manage. In 2015, I discovered that I had colon cancer. So that was horrible, needless to say. I'm sure a lot of people can relate to stuff like that. After that surgery, it went all well, but the surgeons told me that because of everything in the past and because so many lymph nodes were affected, that I would never be able to have just any surgeries again, only if they were ones to save my life. So in the interim, after I beat cancer, I kicked it in the butt, and it's all good. It's all real good since then, but I've had residuals from chemo with nerve pain in my feet, really, really bad nerve pain all over. When I see the shingles commercial on TV and they have lightning bolts all over, it just makes me cringe, because that's perfect description of how it feels when I have a flare up. Now I learn what it is. So I was referred after doctoring and kind of being pushed aside for a lot of it, I have to say, being offered, I went in for some help and was very upset, started crying, and in 5 minutes, a doctor that didn't even know me offered me a prescription for 250 OxyContin. And I was so offended, because that's not at all how I wanted to approach anything. So after years and years, finally my NP had referred me to MAC iOPS. So I was not really committed, or I wasn't really totally interested, because I'd gone to a pain clinic way far back, and it was just another, we'll give you drugs and here you go on your way. I had my aversion to physio. I explained this to, I can't remember who I very first talked to, whoever did intake or whatever it was. And I explained my situation. She then referred me to a social worker, and she coached me. That MAC IOP social worker coached me and gave me tools and gave me what I needed to go to my very first physio appointment, which was okay if I needed to take half an Ativan. That wasn't a deal. She said, whatever, so I was throwing up in the morning. I was so nervous and I was so scared, and I had a little mini panic attack. We're from Watrous, so we're an hour and a bit to the city. And I walked in there, and Isabel met me at the car. That was my physio. I had a cane and limping, and she helped me in. And she knew right away, she knew my whole story because of the wonderful communication that my MAC IOPS has with each other. It's just phenomenal. And she worked me through it. She told me what she was going to do. My first appointment was wonderful. Everything that social worker had given me, I applied. I worked really hard mentally before going, and it worked, much to my amazement. I'd been counseling for most of my life. I've used counseling, but this was a specific towards physio. And then my second appointment in 2 weeks, no Ativan, no panic attack. I limped my way in once again, and Isabel and I went to work, and I applied. I decided this is it. I'm committed. I could feel that everybody was fully involved in my care and in my well-being, and that just made all the difference in the world. So with Isabel's help, in a matter of time, like no time at all, I did my exercises and I could see results. It was just absolutely amazing. And I was looking forward to appointments and new exercises, and I knew I could get back on the motor, because I couldn't get on our motorcycle because my hips, and I had fallen almost exactly a year ago today, and fallen really hard down. I just slipped on a tiny little patch of ice, and the heel of my boot even left a bruise in my butt. I felt all my weight hard on my bent leg. So I had a cane and was in terrible pain. Well, by August, we rode into the city on the motorcycle to my appointment. I walked in just like that, like nobody's business. And Isabel rejoices in every improvement along the way that I made. She was as happy with everything. Oh, it's been fantastic. This has changed my life, my outlook towards my pain, how I've coped with it physically, mentally. Everything has just changed phenomenally. I can't even describe I don't have the words actually, how well it has gone. I don't know what else. I'm rambling.
Well, I almost don't have the words to even respond to that, Giselle, because it is just so breathtaking. Having met you probably about 18 months ago or so, when we first
Yes.
had connected, you, Giselle, are one person who came to our clinic saying, this is what I want to be able to do more of. I want to get back on the motorcycle. I'd like to do more yoga. I like kayaking. I like biking. I like all these things, and I want to do them more comfortably. And to see you have made that progression, embrace the help that our social worker offered you, embrace Isabel as one of your biggest cheerleaders. It's just been so incredible and rewarding to watch that journey for you. So through all that, Giselle, you've lived with pain for a lot of your life, but it sounds like you've had that foundation since 12 years old to push beyond. You worked on the farm with your dad. You had some birthing experiences that weren't so easy. You had a traumatic accident on your motorcycle, and you beat cancer. And so through all of that, I think you had a foundation to know that you're a fighter and coming beyond this pain, limiting your life. So I'm curious, Giselle, if you could tell us what you think has been most helpful for you to manage your pain. What's been most helpful in the past while for you to be able to manage?
Well, again, with Mac iOPS, with pharmacist behind me all the time, Kelly telling me, let's try this, let's lessen this. If this doesn't work, we'll do this. And every step along the way, it was continual communication with, I had questions. I was worried about, oh, my cat just hit this, Gemma. So go. So she through like all these months, it's just been, maybe we should take less Lyrica and add a little bit of this, or maybe if that doesn't work, then re-add this. And it's been a process, but definitely first and foremost, I would say on the right regime of meds has been the number one, the first step, I would say. Once we got that down pat, I also felt more confident to do physio and to push myself, not push, because I know lean towards the comfort and away from the pain, or however that goes. But I also learned to pace myself, because you don't get rewards for thinking you're tough. That doesn't even matter, which I lived for a long time thinking you got to be tough because, but on that same note, I never really thought, well, if I don't know, if I didn't push on, then what? There was no, that you just had to. What options were there really? I don't know. I wasn't being braver. I never even thought of it. I just pushed on. I had little kids, then I had a farm, then I had, I lost my husband in between that. My husband passed away on the rigs in 1998, and I had 3 teenagers. So like everything, I had a whole bunch of stuff going on in my life. And in 2012, I got remarried, and things improve. That's always a thing that a person's got to think. I always try and think that. I always try and look for that little bit of fight. I use the F word, but I make sure that I have that little F you cancer or whatever deep inside of me, wherever it is, whether it's my pain. As long as I can find that little tiny bit of hope, then it just pushes me. It just makes me, and things get better. I know that committing to physio and really seriously committing, not just, I'm really don't feel like it today. Well, that's good, but unless you do it all the time, they don't hurt. You kind of wonder, putting my knees to the side, really, that helps? But it helps. It helps.
Yeah, so it sounds like, Giselle, what you really found is embracing the opportunities that were in front of you. Like you said, when you first got the referral to Mac iOPS, were you all that interested? And then once you actually engaged in it and bought into it and really started to actively engage, that's when you started to find a change that was meaningful for you in your life. Hey, that's awesome. I did just want to go back to that point of medications, and feel free, Giselle, to share as much or as little as you want. But some of the conversations we've had before, you've really been focused on telling me, Taylor, I don't want to be over medicated. If I can reduce to the lowest effective dose, that's my goal. And so I think you're the poster child, Giselle, to say, you know what, sometimes less is more when we have these other things on board, like movement and mind strategies. sometimes we realize we maybe don't need as much medication as we'd initially thought we would have. Hey, there's always that trade-off there, and you're always the person who questions, you know, where is that trade-off, and can we swing the pendulum back the other way? Hey, yeah, right.
Yeah,
on.
I didn't.
So, yeah, go ahead, Giselle.
No, I wasn't. Like, I'd been on numerous things over the years. The drowsy does not cut it for me. The not being able to go to the bathroom. I have very, very little colon as it is that I have to live with. So every little medication will bother me. Either it makes me really ill, or I'm head fogged, not only for 2 weeks, I'm head fogged for 6 weeks. But I mean, with like, I was, you know, I'm able to get back into yoga, do my stretches that don't hurt anymore. And that's it. Everything seems to work. Then when you find the right meds, you have to persist though, and like give it that 2 weeks and make sure that you wait. I'm learning all that. You can't rush all that stuff. You have to do your exercises, and you have to do things that just make you move, even if it's a little tiny bit. It all helps, I think.
Yeah, and to have a good relationship with the people who are encouraging and supporting you around meds. I feel like we've had some really great conversations. You know, at first, maybe you weren't quite on board with me suggesting how much is a sleeping pill helping, how much is it not. But in having conversations, Giselle, I think that kind of built as that trust and communication between us came, where you maybe said, I think I can trust this person. You know, there is some room maybe to change around medications and find some benefit in that. Maybe the last question I have for you, Giselle, is if there is one piece of advice or something that sticks out in your memory as being really that pivot point for you.
There's been many, I have to say. They've all come through MAC iOPS, the positivity, the support, all that. But I would say there's always hope. Isabel told me, if you want to do this like you're telling me, we can fix it, we can help, and we will. And she was right. And I held on to that I could feel that she meant it. And I held on to it real tight with your help, with the suggestions from everybody. You just have to, even if it's tiny little sliver of hope, as long as you have it, things get better. Things always can be better.
Right on, Giselle. You are so inspiring. I'm so glad you agreed to come and share your story tonight. Like I said, you're the first person that came to mind as I thought about who would be a great person to share their story.
Well,
and
that's
it's you,
so
Giselle.
nice.
Amazing. Amazing. Is there anything else you'd like to share with us tonight?
Just, I don't like people. Believe in yourself and believe in the people around you. Trust, even if it's only 1 or 2 or 3 people, you have to trust your support system and believe in your strength, because everybody has a little sliver somewhere, and just dig deep and hard and you'll find it, and it gets better and better and better.
Perfect way to end that, Giselle.
Thanks so much,
Excellent.
Giselle, and thanks, Taylor, for doing the interview, and that was truly inspiring. Thanks so much. And that is a great message that pain can change, even pain that's been around for 46 years, it can change. And that's a very inspiring message. So we have one speaker left. I realize that we are running low on time, but one speaker left. So hopefully people can hang around a little bit and listen to Taylor. Taylor Raiche is a clinical pharmacist with the Medication Assessment Center, and she very much enjoys working with individuals who use medications to educate and empower them so that their medication regimen is effective, safe, and convenient as possible. And she also loves having pharmacy students in the clinic and helping them on their learning journey to become better healthcare providers. Taylor is so looking forward to warmer weather and getting outside more in the next few months. So me too. All right, over to you, Taylor.
Excellent. Thanks so much, Susan. Okay, I'm going to share my screen here. So if you can let me know, let me go. Okay, you can let me know. You can see my full size screen and you can hear me. Kelly, do you want to give me a thumbs up? I see you guys.
All good. Go ahead.
Sorry, folks, I think we're frozen. Can someone give me an idea? Yes, I see the thumbs up. Okay, so hello, everyone. I know we're running short on time, so let me try to cruise through this, but still be as crisp and as clear as possible. So what I'm sharing with you tonight is somewhat maybe of a deeper understanding of what we as pharmacists do in the setting of a chronic pain clinic. And so as has been thrown around a few times tonight, the term MAC-iOPS stands for Medication Assessment Center Interprofessional Opioid Pain Service. And I'm so excited to say that very soon I no longer have to say that exhaustingly long title. We will be called the USask Chronic Pain Clinic very shortly. So I'm going to share with you a little bit today about what we do there. So moving forward, I don't necessarily have anything to disclose other than, of course, I'm a bit biased in telling you about how great our program is because I'm employed by our program. We're funded through Health Canada's Substance Use and Addictions program. So depending on where and when you grow up, this photo maybe looks somewhat familiar to you. So pharmacists in black and white photos are largely Caucasian men wearing ties and white coats, and they're standing in front of all sorts of clear and amber glass jars full of powders and crystals and syrups. And so pharmacists, who are still called chemists in many parts of the world, used to really be known for compounding and concocting all sorts of lotions and potions based on doctors' orders. One of my first mentors actually graduated pharmacy school in 1964, and she told me once, you know, we used to really be discouraged by some doctors from talking to patients about their medical conditions or even telling them what their medications are for. We were basically meant to just make the medication and silently dispense it to the patient, not ask questions. Pharmacies used to sell photos and ice cream or cigars and cigarettes, and in some cases, as you can see here, Scotch whiskey, breakfast, lunch, and dinner. Pharmacy looks quite different in the past than it does today. So nowadays, the practice of pharmacy looks pretty different from the origins of a profession in some ways. And in some ways, some of the core tenets of what it means to be a pharmacist still exist for the past hundreds and hundreds of years. But I wanted to share with you that coincidentally, March is Pharmacy Appreciation Month. So I thought it's probably fitting to show you some photos of current pharmacy teams across Canada in the year 2022. So this is the face of pharmacy in Canada. You see lots of people standing in the setting of community or retail pharmacy. Here you see pharmacists giving injections and vaccinations. On the top right corner, that looks like there's pharmacists in the hospital and somebody back there maybe creating some IV medications. Pharmacists are all over the place and we play very important roles. Again, I'm biased, but I think it's very true in all sorts of areas of the healthcare system. So here's our team. This obviously isn't a complete picture of our team. As Kelly mentioned, we recently expanded and we've now hired some new staff, but our pharmacists look like little Sims in this photo with the red stars above their heads. 4 of us are clinician pharmacists, actually working with people who live with chronic pain and chronic diseases day to day. So that's the second one from the left, and then the 3 on the right. You'll see Kelly and I in that photo. One of the pharmacists here is our clinics director, and one of them is a clinical support pharmacist. So our team is heavily pharmacist biased, which I won't complain about. We work at the Medication Assessment Center, and let me tell you a little bit about what we are. So we've been around for about the past 10 years or so, based out of the University of Saskatchewan College of Pharmacy and Nutrition. For the longest time, it's really been pharmacists working with people on a one-on-one basis to help optimize their medications to make them more effective and safe and convenient by educating them and providing recommendations directly to their prescribing doctor or nurse practitioner how to make things run more smoothly. So we offer a couple of services at the Medication Assessment Center. On the left-hand side of the screen here, you'll see we do general medication assessments, and so I'll tell you a little bit more about what that looks like in a moment. In the middle of your screen, you see our USask Chronic Pain Clinic, and currently MAC-iOPS program, where we have that interprofessional pain management with our physiotherapy and social work colleagues that Kelly was mentioning earlier. And on the right-hand side of your screen, you see that there's a few of us who are actually trained in something called cognitive behavioral therapy for insomnia, or CBTI, to help folks sleep better with less use of medications, which in reality tends to be a more sustainable and actually effective solution for chronic sleep concerns. So what can we do for you at the Medication Assessment Center, more specifically now the USask Chronic Pain Clinic? So at our initial appointment, this is just a sample of the types of questions we start to ask folks. I always tell people I block off an hour, sometimes even 90 minutes for these initial appointments, because once we get talking, we get talking. There's always so much we can talk about. And what I'm really focused on learning from somebody is, where are they at and where do I meet them? So starting with where that person's at in terms of how they feel about their current diagnoses, how their conditions are being managed. You know, do they prefer to take medications? Do they prefer to lessen their use of medications and rely on other strategies? Who do they have in their corner to support them at home or support them on their healthcare team? Are their medications affordable? Are they accessible? What do they try? What are they interested in trying? So many different questions. And like I say, this really can kind of spin into a full 60-minute conversation just as a starting point with lots of follow-up from there. As a pharmacist, though, at the end of the day, it's my job to make sure every single medication, natural product, or non-prescription over-the-counter drug you're using is 4 things. It's necessary for you, otherwise what we call an indication. It's indicated. It's effective for you in meeting your goals, that it's safe, and that it's convenient and accessible for you to take. So in pharmacy school, we're taught that there are 7 of what we call drug therapy problems. So every concern that I might have with a medication of yours could essentially be categorized into one of these 7 categories. And there's a really strategic and methodic and structured process that we're trained to use as pharmacists to go through every single one of your medications and ask ourselves these questions. Do we actually need to add something to better treat a medical condition? Do we need to stop a drug because it's not needed anymore? Maybe there's something out there that's more effective and you can switch it. Maybe you're at too low of a dose and you should increase it. Or maybe you're too high of a dose and experiencing side effects. We need to dial it back. Maybe you're experiencing a side effect or a drug interaction, or maybe your medications just aren't all that feasible for you. And I always say, many of my colleagues do, medications don't work in people who don't take them. So at the end of the day, number 7 sometimes becomes the most important one for us to look at. All in all, I find dozens of drug therapy problems every day as I'm talking to people. But in general, I don't recommend one swing of the bat and change everything all at once. We recommend most of the time, 1 change, maybe 2 small changes at a time, to really be structured about this process over time and ensure that we're working in the right direction with you. So when someone tells me they're experiencing a concerning symptom like dizziness or tingling in their toes or a chronic cough, I'm always working on the hypothesis as a pharmacist that the symptom could be explained by one of 2 explanations. So firstly, that maybe the symptom might be due to an underlying disease or an illness that needs to be treated by medication or non-medication therapy. So tingling in your toes might be a sign of poorly controlled diabetes, and maybe we need to control your blood sugars better, or maybe of a spinal cord issue when your nerve being pinched. There's lots of ways that we can work those things out and help get other people on board to diagnose and get the appropriate treatment. But I always want to remind people too, as a pharmacist, I want to ask, is this symptom caused by a medication? Lots of times we end up finding that side effects are actually the culprits of symptoms. So what we don't want to do is tack on another medication to treat that symptom if we can all help it. We want to try to keep those things contained and not let them spin out of control. So over time, I'll just say that with aging and as illnesses progress over time, I very commonly see people get prescribed more and more medications, and more isn't always better sometimes, but we often know less is more. So I often tell folks that the first medication you're given might be a jazz saxophone player, and the second medication may be a classical pianist, and the third medication is like a bagpiper at a Robbie Burns concert, and a fourth could be like shredding an electric guitar on stage with AC/DC. And so all of these medications, like you might enjoy the concert, enjoy the music on their own, but when they're all playing different music of different genres, it's a cacophony. It's really hard to actually identify what sounds familiar, where are these sounds coming from. So sometimes it really is a matter of kind of parsing out each of those individual songs and figuring out where do we go from here. Not all combinations of medications are harmful, though. Lots of times we find instruments that can play in the same orchestra and really make music worth listening to. But sometimes when I see medication lists, I'm like, we've got about 12 different songs playing here. We need to actually get everyone on the same page, start up the orchestra again, and reignite something that sounds like music. So as Kelly said earlier, at the Medication Assessment Center, our approach, at least with chronic pain, is really to take that 3M perspective of focusing on mind, movement, with medications being a part of that. We've tried really hard to build relationships with the folks that we meet who live with chronic pain and really get to the root of understanding what's important to them and what they want to achieve out of their medications and other strategies, and make recommendations that really make sense for their unique situation. So I often tell people, it's not a quick fix. I can't get you to wake up tomorrow morning and feel 100% better, but I'm going to try over the long term. We're going to work on this together. And it's not often a one-size-fits-all approach. Every recommendation I make comes from a very unique assessment that I perform for that individual. So I will just summarize this slide by saying that our treatment plans are personalized to you and your needs. We work directly with care providers in the community, whether that's family doctors, nurse practitioners, community pharmacists, physiotherapists, mental health workers. We try to connect and collaborate as much as you're willing to allow us in being a patient of our care. And we certainly support our individual patients ongoing with education and resources to round out their self-management. So any pharmacist, like ever, in community pharmacy, hospital, any practice in the outpatient setting like ours, should be able to go through this really structured medication review process with you that I just gave you a little taste of today. In community pharmacy, we call these Saskatchewan Medication Assessment Programs, or SMAP. So sometimes you'll see that advertised by community or retail pharmacists. You can always ask them to say, hey, can I get a medication review by anyone on your staff? Is there an opportunity for us to sit down and go through these things? If you're interested in coming to the Medication Assessment Center or the USask Chronic Pain Clinic, we'd love to see you. You can fill out a self-referral on our website, which is www.usask.ca/pharmacist, and you can see where that big red arrow is. That's our refer button. You can fill out your referral online, give us a call, and we can walk through it with you. Or what's even better yet is to actually chat with the person who's prescribing your medications and say, hey, I think I want to check out this medication assessment center. Can you help me work through a referral and identify what sorts of things we should be focusing on? And that referring provider can send your information in as well. So here's our contact information. As I mentioned, our website. You could also give us a phone call and we can walk you through there. You will find that we are rebranding, and like they say, you will notice we're called the USask Chronic Pain Clinic moving forward very shortly. Lastly, I just wanted to share with you, because it's Pharmacy Appreciation Month, if you have a pharmacist, whether it is in your local community pharmacy, someone that you've met in any other setting that you think does really good work, you can actually nominate them this month for a national award and have the chance to win yourself a tablet in the process. You can go to pharmacist.ca/myfavepharm and share your story about how a pharmacist has been helpful in your care if you've happened to be one of the folks who've had a positive experience with pharmacists in the past. That's all I have for you folks, so I will leave it there.
Thanks so much, Taylor. That was awesome. And we have gone a little bit over time, but if anybody has questions, we welcome a couple of questions right at the end here. But while people are thinking and possibly typing, I will extend my thank yous to Taylor and Kelly and Giselle. Thanks so much for sharing your information tonight. Really appreciate it. And I will wish everybody a good night, and you're free to go. But yeah, if you'd like to stay on just for a minute or two, we'll have a little bit more time for questions. So just a reminder that we will be creating a YouTube video out of the presentations, and we will be putting it up on our YouTube channel. So we will share, you can actually just search for Partners in Pain on YouTube and find the videos there. At least on my algorithm anyway, they pop up first, but that's probably because I'm looking for them all the time, who knows. But you will be able to access them, and we will also share the links with you through our email. We'll send out the emails with all the information. We will send an email tomorrow with the slides or any other handouts that the presenters have shared, and a link to our evaluation survey. So it's really quick to do the survey. Please, if you could complete our survey, that's really helpful for us to evaluate how people are liking this and whether there's anything we can do to improve it. And thank you again to our sponsor for tonight's session, the Saskatchewan Workers' Compensation Board. And our next webinar will be March 30th, and it'll be in the afternoon, 2 p.m. And our theme for that webinar is cannabis. I know there's been lots of questions about that. And so Dr. Robert LaPrairie, who's a researcher at the U of S, will be presenting on cannabis for pain management. And please share information about the webinar with your friends, family, people who meet on the street. We want to share the word about Partners in Pain. So please let everybody you know about Partners in Pain and invite them to come and join us on March 30th at 2 p.m. And I don't see any additional questions. And so I wish everybody a very safe and healthy evening, and we'll see you in a couple weeks.